good for that PSW. Actually, it was not a PSW. It was I think it was a
EMS. It was EMS.
EMS was an EMS that sent that big tweet with everything included. I tell you, is yeah. Everybody, we are absolutely thrilled that you have chosen to dedicate part of your beautiful evening with us to discuss a hugely important and quite frankly devastating topic, which is the faith of seniors in this country, and more in particular, the faith of residents in long-term care homes across this nation. I'm Doris Greenspoon. I'm the CEO of RNAO. We have been very involved on this for many decades. And now it's time that we put our heads together and see where it can lead us. We have no promises for the rest of the evening, except that it will be a very good evening, just based on the speakers that you will hear and the perspectives that you will hear and the moderator that we have. This is not a topic that we want to get at, you know, to fight about, but to fight for. So all of us together. And whether this will lead, I was talking yesterday with André Picard, our famous André Picard, who gracefully agreed to moderate the panel. I said, where this will lead us depends on all of us. We have no promises, except that we know that in Ontario, we will continue like a dog with a bone until we get something. And as of today, I can tell you that I'm more hopeful, but time will tell. Ideally, we can get somewhere across this country, because seniors are across this country and are the ones that build this nation. So with that, let me introduce you to André Picard. That needs really no introduction, probably to 99.9% of the people attending. He's a health reporter and columnist with the Globe and Mail. And recently, he finished a book that will come out, I believe, in March or April, he will tell us, titled Neglected No More: The Urgent Need to Improve the Lives of Canada's Elders in the Wake of a Pandemic. To preamble that, I want to say that the tragedies in long-term care are way, way before the pandemic. The pandemic only served as a horrific magnifying glass. And if we don't succeed now, that things are in our face and in politicians' face and in the media's face, if we don't succeed now, it is my view that we will not succeed never till the next horrific event, another pandemic, because we have had many smaller events, equally horrific, just more localized, and nothing has changed. So with that, Andre, it's all yours to manage us. Thank you.
Great. Thank you, Doris, and welcome everyone. Welcome to everyone online to the panel Mobilizing Collective Action for Long-Term Care Reform in Canada. As we all know, the coronavirus pandemic has dominated the news headlines for much of 2020. More than 50 million people worldwide have been infected, and at least 1.2 million have died to date. And the pandemic is only now just picking up steam. It's not dying off, it's getting much worse. Canada hasn't been spared. We have about 270,000 confirmed cases and more than 10,500 deaths to date. And in Canada as well, the pandemic is picking up steam. What distinguishes Canada from the is that the large majority of our deaths have occurred among our elders, particularly those in institutional care, like long-term care homes, nursing homes. The carnage has shone this bright spotlight on the inadequacies of elder care in this country, and there are many inadequacies. We have gaping holes in our social safety net for seniors. We have a Medicare system that largely abandons people once they're outside hospital. and we have public policies that are quite ageist and have been for a long time. There's a lot to fix, but with so much attention focused on this disaster, we have an unparalleled opportunity to fix it, to fix elder care once and for all, both the nursing home sector, the home care sector, and of course for the many people who live in the community in their homes. All of them need help. So that's what we're going to discuss tonight, a very broad, vast topic. We're going to talk about the problems, but we're also going to talk about the solutions. We're going to talk about how we can force politicians to finally deal with this once and for all. We have a superb panel, so I don't want to take much time. I want to leave it to our panelists. We have a superb group of panelists that the RNAO has brought together. Each of them is going to speak for about 5 to 7 minutes. Then we'll have a question period, which I will have the pleasure of moderating. So be sure to send me your questions. The RNAO folks are going to get them and they're going to group them into themes. We can't answer every individual question from all 400 or 500 of you online, but we'll get some themes and we'll try to get as many questions and issues tackled with as we can tonight. So let me introduce very briefly the panel. You saw them in the introductory slide, but I'll just read their very short Twitter-length bios and then we'll get to them and give them the time to talk. We have with us Nathan Stahl, a staff geriatrician at Sinai Health System. Nathan, you can give us a wave. Hi. Doris Grinspan, who you know, of course, she did the introduction, the CEO of the Registered Nurses Association of Ontario. Shirley Sharkey is here. She's the president and CEO of SE Health, a national home care agency, which old-timers like me still refer to as St. Elizabeth Healthcare. It's old-fashioned name, but SE Health is a new name. Hi, Shirley. And we have Miranda Ferrier, the National President of the Canadian Support Workers Association and President of the Ontario Personal Support Workers Association. PSWs have we finally realized they exist during this crisis for all the wrong reasons, but Miranda will talk about us about that a little later. Linda Silas is here with us tonight. She is, of course, the President of the Canadian Federation of Nurses Unions. And she's going to talk about some workplace issues. And last but not least, we'll have Laura Tamblin-Watts, President and CEO of CanAge, a national seniors advocacy organization. And she's been very busy during the pandemic because there's a lot to advocate for, a lot of change to advocate for. So as you see, super panel. So we'll get right to it. And we'll get Nathan to start us off, if you could, to give us some context, some data about what's going on in Ontario and Canada, and kick off our discussion.
Perfect. Thanks so much for the introduction and thanks for having me. So I am going to share my screen. Should be able to see this. So I promised Doris I would not go over 7 minutes, so I will be quick, but I want to present, to give the context for tonight with some data. I titled this our National Shame, COVID-19 and Canadian Long-Term Care Homes. I really have no conflicts of interest to disclose. I do receive some support for my research and income as an associate editor at the Canadian Medical Association Journal. And I'm going to talk just very briefly, quick overview of the epidemiology of COVID-19 in Ontario and Canadian long-term care homes, and then some of the research we've done in Ontario about factors associated with the risk and spread of COVID-19 outbreaks. And there's many things I could present on. I've chosen to focus on 2. So, briefly, if you look at the age distribution of cases in this country, we've had over 250,000 cases as of yesterday. There is a pretty wide age distribution of cases in the country, including a bulge around the middle ages. A lot of those, we've seen a greater number of infections recently in the 20 to 29-year-old. But as they were warned for the second wave, these cases have leaked over into the older age group. This is by gender. You'll see that there are actually more cases among women than men. And that's also, bulged in the middle age, probably because there are more healthcare workers and educators who are women than men, and also in over 80, because the common theme here is that women are the superior and stronger sex, and they live longer and are stronger than men at the end of life. But when you look at really the distribution of hospitalizations, really skewed towards older adults, the vast majority being above the age of 50. And here is where you start to see actually men have more hospitalizations than women. So they actually have more severe disease than women do. You start to see for ICU admissions, again, the vast majority are over the age of 50. Again, men have worse outcomes than women despite having less cases. That's been shown over and over again through this pandemic. And then the deaths is just phenomenally skewed towards older adults. Over 97% of all cases are over the age, or all deaths are just over 96%, just under 97 are over the age of 60 in our country, with the vast majority of those over the age of 80. And where are those? A lot of those people, they're in long-term care homes. So long-term care residents are at high risk of contracting SARS-CoV-2 because of congregate living. They're exposed to staff. Visitors, we actually don't know whether they contribute. There's no evidence they actually have been involved in the transmission of SARS-CoV-2, the causative infectious agent of COVID-19. And there's challenges in this population with physical distancing and hand hygiene. 70% of residents have dementia, 90% have some form of cognitive impairment. And I should say the staff unknowingly may have imported the virus and weren't necessarily given early on the proper personal protective equipment, including universal masking, to prevent this from happening. And of course, there were many issues, as we'll hear throughout the night, that led to the catastrophe that I'll briefly describe in the data. They're also at increased risk of COVID-19 morbidity and mortality. So advanced age is probably the minor player here. There is a phenomenon of immunosenescence, where as you age, the immune system becomes less robust. But probably as you age, more importantly, that you accumulate comorbidities. And so long-term care residents have many medical conditions, take many medications, and we saw stunning case fatality rates of 1 in 4 to 1 in 3 residents who get infected that go on to die. These are, of course, a photo from the Camilla Care Home, one of the most tragic sites in Ontario of a long-term care outbreak. This is data from the National Institute on Aging Long-Term Care Tracker. It's actually sad at this point in our pandemic. Even PHAC doesn't have aggregate data on COVID-19 in long-term care homes, and forget about retirement homes or other congregate care settings. So they've aggregated it. You'll see we've had almost 8,000 resident deaths in our country. The vast majority have happened in Quebec and Ontario during the first wave, but we're seeing this pick up in other jurisdictions now, particularly out west. And that figure hovers somewhere around 80% of all of our country's deaths have occurred among long-term care home residents. If you look internationally, Canada is the top dot there. This is from a fantastic resource called LTC COVID run out of the UK. But again, this was earlier on, but about 80% of deaths, so the highest number of all known countries, have occurred among our long-term care home residents. Of course, we have much fewer deaths and much fewer deaths per capita compared to somewhere like the United States, but certainly we have that dubious distinction. If you look in Ontario specifically, this is actually presented during the LTC Commission, the concept of excess mortality. So if you look, this is from the first wave. The yellow at the bottom of the graph there would be the mortality we would have expected in 2020 had there been no pandemic. The orange with the dots are the excess non-COVID deaths we had during this time, and the red are the excess COVID-19 deaths. So many people talk about excess mortality as the true measure of death during the pandemic. This has come to light with some controversy from some of our decision makers saying that this year was no worse than a typical flu season. That's absolutely not correct, certainly on the basis of these excess mortality statistics that I'm displaying here. And this has been shown not just in Ontario, but elsewhere. This is from today. I tweet this every day. I've been tracking in wave 2 in Ontario. We now have, as of today, 625 active resident cases. Think about when you have a case fatality rate of 1 in 4 to 1 in 3 residents dying, you can expect more tragedy, sadly. Perhaps the case fatality rate is better during the second wave, but certainly some of those residents will tragically go on to die. We have 96 homes under outbreak. We had 9 deaths today. We've had a substantial amount of deaths in the last 2 weeks as the COVID-19 pandemic in the second wave intensifies in Ontario. So very briefly in the last couple minutes, just a couple of studies that we've done. This was published in the Canadian Medical Association Journal. I think it's relevant here. We looked at from March 29th to May 20th. Really one thing we heard over and over again, I think this will feature into some of the conversation tonight, which is why I wanted to bring it up. What was the impact of for-profit on COVID-19 outcomes in our province's long-term care homes? We looked at 3 outcomes: whether you were going to have an outbreak, how large the outbreak was, the extent of the number of resident cases among in the home. So how many cases did you have in an outbreak, and then the number of deaths. What we found was, so there were about a third of all homes had outbreaks, and the case fatality rate really lined up with what we saw early on in Washington State at 27.8%. Importantly, the odds of having an outbreak are not associated with the profit status of a home. It's associated with the incidence of COVID-19 in the public health region that was surrounding a home. And that's critical because, as we have been saying over the last, we're into the now into the third month of we consider it September 1st, the second wave is starting. As the community incidents rise, we predictably see more outbreaks in our long-term care homes. But what we did show was for-profit status was associated with outbreaks that were about twice as large and involved 78% more resident deaths compared with nonprofit homes. Importantly, and I think this is really critical, it wasn't all for-profit homes, and not all nonprofit homes did well. There were some that did poorly as well or had bad outcomes. It seemed to be the ones that had older design standards, so those that met or fall below those established in the year 1972 that had a lot of multi-occupancy rooms, and those that had chain ownership that really did the worst when it came to these outcomes. So that's why it's important not to paint the whole sector, the whole for-profit long-term care sector, with the same broad brush. And some of the risk assessment tools the province now use takes those factors into consideration. And the last minute, this was actually just published today. We released it as a preprint earlier in the summer. We looked at crowding in nursing homes, and I think this is really critically important as well. Same time period, we built a simple crowding index. We said, what if you look at outcomes of COVID-19 based on the average number of residents per room and bathroom in a home? So if every resident in the home has has their own room and their own bathroom, your crowding index will be 1. Of course, we don't have any homes like that in the province, but we do have homes where the crowding index is 4, where there's an average of 4 residents per room and bathroom. So we looked at the cumulative incidence of COVID-19 infection and mortality. And then our negative tracer, meaning we didn't expect to see this happen, was introduction of COVID-19 into the home, because again, we felt based on our previous study that it would be the incidence in the community surrounding a home that would best explain whether a home got into outbreak. And again, we see this really strong relationship. The incidence is on the y-axis, the crowding index on the x, and if the more crowded your home was, the higher number of the cases you had in your home and the higher number of deaths. And we simulated that pre-pandemic, had the government converted, and the whole sector really, I'm not going to explain, but converted all 4 bedrooms to 2 bedrooms, we could have averted 1,000 COVID-19 cases and about 263 deaths from the first wave. So that was sort of my brief overview of the epidemiology to set the stage, and I'm happy to hand it back to Andre to introduce the other fabulous speakers on our panel.
Great, thanks, Nathan. A great introduction, and you give us lots of fodder for questions, which we'll get to soon enough. So next up, we'll ask Doris. Doris, the RNAO has been trying to promote this basic care guarantee for a long time. So tell us a little bit about that and how it's progressing because of the pandemic. I have to unmute you.
I was saying thank you, Andre, and thank you to Nathan for setting the stage. And as you were talking and getting to the end, I was thinking, oh, shoot, I didn't put David Fishman's famous slide. You know which one? The pandemic of the tale of 2 stories, or the story of 2 tales, however it is in English. La historia de dos, right? Where we see that it's going down in the general population, and yet it's going up and up and up in long-term care, because that's the reality what we have done. And while at the beginning, to tell you the truth, RNAO bought the story and believed on the story, and I think most of us did, that we needed to keep families out to protect our residents, right? Pretty soon after the mess started, we said, this is no good. So before even I touch on the issue of the basic care guarantee, I want to touch on the issue of reuniting families, because we went quite early pushing for the issue of reuniting families. Because quite frankly, we felt as nurses and overall for politicians that we were cheating the families. We had told them, we will keep you out to protect your loved ones, and yet we didn't protect them. So we felt like cheaters. So we decided to come clean and start to push directly at the Premier's office, and then in other means, media in particular, to reunite the families. And on that piece alone, I credit the Premier for moving it, and a particular person in the Premier's office, because Minister Fullerton was nowhere to be found on this issue at the beginning. So I say this because it gives you a little bit of hope. In the midst of devastation, it gives you hope that if you touch the right chords maybe we still can find solutions to our other challenges. So reuniting families is not perfect, but at least the doors were open. RNAO pushed that families be reunited as essential care partners, and our colleagues, Nathan and Samir and others, also with Anya and others. I know you, Laura, and others too. Where we took a different stand is that also in homes that have COVID, we believe, and to this day, we believe in homes that have COVID, families have a right actually to be in. So with that, let me move to the second piece where we have made zero progress because the premier, the minister, and whoever else for that matter, can announce 20,000 times about 4 hours, 4 worked hours of care. There is nothing until there is money in the budget and directive for homes to actually hire the people. So no good news for me. Everybody jumped clapping that the 4 hours was great news. Not in our book of RNAO. We only announce good news when the check is signed and the good is delivered. And I spoke about that with the premier today again. So on this issue of 4 hours, basically we want everybody to be lifted up in terms of numbers and in terms of skill mix. Right now, they're delivering 2.7 hours of care if you look at worked hours. The premier will say 3.5. Well, that's when you count vacation and sick time and everything else. I'm talking worked hours of clinical care, of nursing and support for the residents, direct care hours. So we are saying 48 minutes of an RN, because that's links with the staffing study of the minister herself, 60 minutes of RPN care, 132 minutes of PSW at minimum. And these are worked hours, does not count holiday, does not count vacation, does not count sick time. We are also saying, and have been saying for years, 1 NP for 120 residents in the role of attending nurse practitioner or director of clinical care. And we have only 60 homes, because this started with our request from Minister Matthews back then. And so we have 60 homes with nurse practitioners. They all delivered better care. Those nurse practitioners were on site. And lastly, we are asking for 1 full-time RN in specializing in infection control. Listen, people, hospitals have a whole army of people for infection control. We're asking 1 person. Just give us 1 person for long-term care. I said to the minister and the premier today, to Minister Elliott and the premier today, you can put the hospitals 20,000 times to help the nursing homes. Until you do not develop the capacity inside the nursing homes, you ain't going to make things better. And ask our colleagues, whether it's PSWs or RNs or RPNs or NPs in the front lines or doctors, because the hospital comes and leaves and nothing happens. You need the capacity inside the home, and I will leave it with that for now, Andre, and others can take it over from there.
Great, thank you, Doris. Our next panelist, Shirley Sharkey, who is an expert on home care, been in the sector for a long time. Shirley, tell us about the home care aspect of this.
Where to begin? Well, I'm glad, Doris, you talked about funding, because that is a very important starting point no matter what we do. And I'll talk a little bit about the context of home care, in that certainly Canada underinvests in care for seniors, and in particular in home care for seniors. From CD Howe, the amount of money that we do spend, which is much less than in every other country, 90% goes to hospitals and institutional care, and 10% goes to the community and home care. Compared to other OECD, the peer average is 35%. So we're 10% of a small amount versus the 35%, and it's still of a small amount. And this slide is just to show about the capacity when we look at long-term care from a beds, a facility, a building, etc. If we really thought about it differently and talked about managing the frail elderly, the aging in their home environment, and providing the kind of care that they receive in long-term care institutions, we could certainly expand capacity with much less resources for capital rebuild and developers and that whole aspect of care. Interestingly enough, there is a mismatch between what people want and experience and the options that are available for them to receive care at home or create this kind of long-term care capacity. And I would say this is throughout Canada. 90% of people prefer to stay at home. At this moment with the pandemic, 95% of Canadians think that home care is in fact the safest place. And certainly the statistics have played that out with the congregate living and the infection spread in those settings. And we've heard for years and years, well over 70 to 75% of people would prefer to die at home. And though we still continue to see very large numbers dying in the hospital setting. So above and beyond standards that are so critical, we need an entire, I would say, rebase of home care and services for people. Now, Doris is absolutely right. There have been, and I think, Andre, you wrote about Groundhog Day and the number of reports we've had. 2007, RNAO had a report for long-term care. Then there was my own report, the Sharkey report, 2008, for standards, guidelines, and long-term care. For home care, we've had more recently, but the Canadian Home Care has put in place some very, I think, effective high-level discussions of principle-based standards, operational standards, clinical standards. So there's certainly no need to be articulating the standards. And in fact, you know, at one point I used to think standards are a given, and therefore we actually, to excel and demonstrate excellence, we have to go beyond minimal standards. Here's the sad thing, I was wrong. And that in fact, with senior care in Canada, it is not a given. And in fact, it is critical at this point in time that, and I would say we leap into concrete, immediate, and timely measures that actually can be implemented that help us understand we actually are delivering and moving through these kinds of standards. Now, I'll just talk about a little bit of why home care is different, not in the sense that it needs standards too, but I would say the starting point is a little bit different in home care because it is more about how to support people to stay in their environment versus the kind of support and care they're getting in an institutional setting. And what's critical within that, and we hear a lot about this, and I would call it shared decision-making with the family, because the caregiver is there in such an important role, and shared decision-making because they're in their own home and they want to decide what they need. And the care needs to be more than medical care or even health care, but life care that allows them to manage their chronic illness or their lifestyle and live in their home as long as they're able to. And in fact, I was really pleased with the recent speech from the throne that said, we need to support seniors to stay in their homes longer. We sure do. But to Doris's point, you got to put your money where your mouth is. And we have to make sure we're able to fund and support the kind of standards that we are talking about. I think what is probably the most important message I can leave is that time is of essence. It has been roughly 25 to 30 years where so many of us have been advocates to talk about the future of aging and the rethink we need for long-term care as a system of long-term care for people in the community, in their homes, in institutions. And we probably need to rebalance the health investments in our system. And if anyone looked at the Ontario budget, home care was not discussed.
Yeah.
And in order to have the talent we need, and for goodness sakes, I hope we don't dilute the talent we have and have aides for aides of aides of aides versus really personal support workers, health professionals, and the qualified staff to provide care for people in their home and be able to give them the tools, the resources, the compensation, the dignity, and the value that not only our talent need, but our seniors need. And I'll leave you with that key advice. Time is of essence. 25 years ago, I thought the time was here. So I think it's now really important that we move. And I think the title of this, Doris, was how do we get action? How do we get this activity moving forward? And I must say, if RNAO and Doris doesn't do it, then I worry if we're ever going to be able to turn the corner on this. So I'm all for action, Doris. I'm right behind you.
We need to go to it together now.
Great, thanks, Shirley. And Doris reminded us in the chat, 35 reports in Ontario in 21 years. The Royal Society said there have been 150 reports on how to improve elder care since the advent of Medicare. So we're not lacking the information on what to do, we're just not doing it. So next up, we have Miranda Ferrier. She's going to talk to us about PSWs. In Quebec, where I live, we've come to call them the guardian angels. They're finally have been recognized their importance during this crisis. So Miranda, the virtual floor is yours.
Thank you so much, Andre, and thank you, Doris, for having me here today to speak to this very important issue that, amazingly enough, personal support workers or CCAs or HCAs or PCAs, whatever you want to call us across this nation, we are finally a part of the national and provincial conversation surrounding this very important issue. So just to speak about personal support workers in long-term care briefly here, I think we all know what PSWs or support workers do, but we're primarily responsible for the bathing and the feeding and the dressing and the overall everything, not medications or assessing or wound care, etc., but everything else that someone would do for themselves in a day, activities of daily living, that is what the personal support worker does. We are seeing, and I totally agree with Shirley, we are seeing a massive change in our system. I think we can say, Doris, that going back years and years and years ago, we knew that there was a staffing shortage of personal support workers going back over a decade. I myself am a personal support worker working I worked in long-term care, I worked in home care, and I worked in hospital as a PSW, and I never worked a fully staffed shift in long-term care. So unfortunately, when this pandemic hit, the government was already aware of the fact that we didn't have enough personal support workers, and unfortunately they chose to ignore that issue for the last decade, and look where we are today. What we're seeing in the long-term care world, even before the pandemic, was recruitment issues for the personal support worker. We couldn't fill the classrooms. We couldn't keep them once they came into long-term care, and unfortunately sometimes too into home care. Both jobs are very difficult. I think that's one thing I've really noticed through this COVID-19 is the public and policymakers kind of believe this job to be easy, and that requires no skill to be a personal support worker, which unfortunately further hampers the professional profile of the PSW. And it is completely and utterly untrue. The job of a personal support worker is hard. It is not only hard physically, it is hard mentally, it is hard emotionally. If you think about the fact that there's no set ratios in long-term care, the fact that, you know, a PSW can be taking care of up to 20 to 25 residents on any given shift. We all read the military reports that came out. PSWs was one personal support worker to 50 residents. These are ratios that are unrealistic, that never should be the case. I had someone say to me that, you know, being on the front line of this COVID-19 through the first wave was literally like being on the battlefield in a war. They couldn't handle it. We've seen a lot of mental health decrease for PSWs, trauma-based mental health issues. I think with PSWs being front and center right now, they were always the invisible worker prior to this pandemic, unfortunately. They are a vital worker, and they need professional recognition as such. So I think we need to look at professional stabilization of this sector. You know, everyone needs help. We're all an important part of the interdisciplinary healthcare team. And in order to assist our most vulnerable and give them the quality of care that they deserve, we need more personal support work. So I agree with you, Doris, what the RNAO is trying to achieve, the 4 hours of care. We definitely stand behind you on that fact. You can definitely come to us for support. And yes, put your money where your mouth is. The time is now. Thank you.
Thank you very much, Miranda.
Great, thanks, Miranda. And we'll talk more about these issues. A lot of questions coming in about PSWs, so we'll get to some of those. Our next speaker is Linda Silas from the Canadian Federation of Nurses Unions. Linda, bienvenue.
Bonjour, bonjour. Bonjour, everyone. Thank you very much for RNAO for the invitation, but mostly for keeping the topic alive. When I heard Shirley's presentation, I thought, how many times did I see Shirley Sharkey on a stage somewhere promoting home care? And then when she said 25 years, I thought, oh, my hair should be the same color as André's beard right now. But anyway, nothing will happen without the staff. We're not going to produce quality care for residents without the staff. We're not going to have national standards without the staff. And if we treat the staff like crap, they will not stay. Miranda talked about the invisible worker. And I do agree, personal care workers have been invisible. But to be honest, the whole long-term care sector have been invisible. It's not the hot and sexy of intensive care, of a big surgery. So it's been so hard to put it to the attention of any politicians. It's hard. André talked about what distinguished us in Canada, that 80% of the deaths were from long-term care. But also what distinguishes us in Canada is 20% of all positive care are a positive case of COVID-19 are healthcare workers.
Yeah.
And the majority of them are from long-term care. Today, I'm hoping that people from Manitoba are listening. We lost another member of the healthcare team to COVID. Just recently was announced today in Winnipeg. The QP family is now again mourning. We've seen that sector of healthcare workers really being hit hard. And most of the time, it's not lack of training. They know how to do it. It's lack of equipment and lack of staff. Already we were working so short in what they're doing. I met I'm not going to name the premier because I didn't ask his permission, but last week with one of the premiers in the Atlantic bubble, and he was saying, Linda, don't worry, there's N95 in every long-term care sector in this province. I said, no, there's not. You want me to give you example? And we gave him example. And then there are others that had N95, but the staff weren't fit tested with it. So what's happening there? We as labor has asked for a national standard, and it was a big debate because who wants to reopen the Canada Health Act? We've been talking about national pharmacare program, we've been talking about long-term care, but it has come to a point that we need national standards. If you go deliver a baby in a hospital or you have a heart attack, you know that there are standards across the nation. In long-term care, nothing. We have guidelines and standards for daycares in this country for how many children a daycare worker can have. We do not have that in long-term care. Even if the win in Ontario for the 4 hours of care is not a check the box for Doris yet, it's still on paper. In Ontario, you said, Doris, about 2.75 hours of care. Some provinces don't even have 2 hours of care per day per resident.
Don't say that.
Don't say that. This is a national conversation.
This is a national shame.
It is, and that's what Nathan said. You know, it is quite embarrassing. So it's important there. We need guaranteed staff. We need the federal government to be leading this discussion. This is not an Ontario, or right now I'm sitting in New Brunswick or a Manitoba issue. It's a national issue. We need national standards, and they need to be attached to funding. And the funding has to have strings attached, which means the staffing levels. We talked about the 4 hours of care. Research says 4.2, 4.25. Honestly, if you give us 4 hours of care per residence per care with a good skill mix, we'll be happy and we'll be making it fix. But also the working condition of these employees. They need full-time jobs. They need benefits. They have to be equal to the hospital next door. All of that has to be worked. And Shirley's right. It has to be linked with home care. None of us work in a silo. You know, people say, oh, Linda, you represent the nurses of the country. I agree. But as healthcare, it's a team. And none of us work in our little offices, because in healthcare, you don't have offices. You work as a team and everyone is interlinked and important. So it's important to do that. So again, you won't have standards, or standards won't be worth anything. Quality assurance won't be worth anything if you do not have the proper staff to do the work. And that proper staff have to be treated with respect and parity to the hospital. Thank you.
Thank you.
Great, thank you, Linda. Lots of issues again there, and some questions coming in about national standards, and so we'll get back to those. Our final panelist before we get to the Q&A is Laura Tamblin-Watts, joining us from lovely Sandy Cove. Laura?
Thanks very much. We really appreciate this discussion today, and if I can make sure I can share my panel, so perhaps the host could turn it off and I'll share some slides today. So I am very pleased to join you from Nova Scotia. I do divide my time across this country, and so some of my comments really will speak not so much to the Canadian experience within the Ontario context, but actually the pan-Canadian experience. So bienvenue à tout le monde. It's lovely to see you today. So I know that we're all in many ways agreeing with each other. And so what I wanted to do was talk a little bit about the work of CanAge and what we're doing to try to support actions, not just within the nursing realm, but actually in a broader policy environment. So I don't need to tell anyone on this particular webinar how important it is, nor do I need to say how many reports we have. We have excellent evidence. Really, what I want to talk a little bit about is the sharp relief that COVID has drawn this to. And so just to take a little step back, CanAge is Canada's national seniors advocacy organization. We're an independent, not-for-profit, nonpartisan organization. We welcome all of you to join. And I've put some information on the chat about it. When COVID came, we wanted to know what we could do to help. And what Canada has been missing, amongst some other direct actions, but what Canada's been missing is actually a plan for aging. And so we did the lift, we did the work. We, in 5 months, put in, all of those commission reports, all of those reviews with regards to aging, not just within the context of long-term care, but looking across the aging issues, and wanted to identify very specific ways that we could action out, and not just ways that we're asking government to do either provincially or federally, but different ways that communities can help to support positive change. And so I just wanted to take a minute and introduce you to what we're calling the Voices of Canada Seniors, and I invite you to go on our website. You can download the map as well. But I just want to show you the interactive way that we've put the report in. So if you click under C, you'll see that we include caregiving, long-term care, home care, and housing together. Really recognize we're not trying to talk about acute care. We're not trying to talk about putting long-term care into a medicalized model, but thinking of it within a more health and housing continuum. And we have some very specific recommendations that I just wanted to share with you. And again, they, I hope, resonate with some of the issues that you're thinking about and some of the experiences that I'm seeing in the chat. One of the issues that we're talking about really in the time of COVID-19 has been, of course, national quality standards. And just to open that up, we're interested in trying to see about how we can think about intersecting our federal government with our provincial government. As a lawyer, I promise you, it's not as easy as it may be, but I think Canadians are very tired of having our division of powers being used as an excuse for inaction. There is a way of doing it, and we're calling upon a review to look at ways that our comparators in Australia, who've had a very different response in managing COVID-19 in long-term care. And there's a number of really important reasons. And we just want to draw attention to them. Dr. Schall's indicated some of those reasons have to do with how many people are in rooms and bathing facilities and so on. But there's also different regulatory standards, including a national regulator, which works in a division of powers similar to how Canada works at. So we're really encouraging looking at that model for action in a Canadian one. Again, I think Canadians are very tired of their division of powers being used as an excuse to do nothing. We also strongly believe that we need to tether funding across the health and housing continuum. So again, Shirley, thank you for all of your service and your reports in home care, and my other colleagues, and Linda. All of that work needs to be tethered to some supports from our federal government. But what we have seen before, and home care is one of those areas we've seen it, is where there's specialized asks to the federal government. If they are not tethered to requirements, they end up in general revenue, and we never see it again. I'd like to know where all of that home care money went. And yet when we have seen tethering of funds and requirements of specific metrics, we have seen success. As an example, the HPV vaccine initiatives, hip replacements, knee replacements, and cataract surgeries, amongst others. So we believe very strongly that, yes, national standards, yes, look at a national regulator at an arm's length, the way that we're looking at the Australian model, and tether funding with requirements to provinces. That way you don't actually lose the money into general revenue, but at the same time. I'm not going to tear about staffing reform because there's nothing left to say that our experts on this panel have not said. But what I would offer is that one of the issues that we really believe is not just about ratios and hours and so on, and not just paying people living wages with benefits and pensions and paying staff by the work performed, not the location that they perform it in. But we need the proper health and housing strategy. We need immigration to play a role. And we also need to be thinking about that intersection of types of care provided. Our heroes, our heroines that we're seeing, Miranda, of which you're representing, our personal support workers, care aides, and so on, they can't do everything. They're not supposed to be able to do everything. We need physiatry. We need rehabilitation medicine. We need audiology. We need care at home, not home care. And you see that our issue 25 is we're talking about changing the model of care to care at home, wherever your home is, whether that be in the community, whether that be in some type of supported housing, assisted living, whether that be in long-term care, care at home with a vertically integrated model. And the last thing I'll just focus on is that, there are some pieces that we can do quite easily that will also make a positive benefit. One of them is to look at how we can ensure emotion-focused or transformative care. I am very worried about the remedicalization of the long-term care home system during COVID-19. Yes, help from hospitals is good. Yes, tethering to different systems to support staffing is good. But the many narratives look like a remedicalization of the care, and we're going to be watching that. I'm very concerned about that. There are some other pieces I just want to conclude with, which is to make sure that we don't just have an Ontario-focused model. Speaking as a Vancouver person who's in Nova Scotia, I promise you the Ontario experience is not the experience of all Canadians. And we need to make sure that we are respecting the different regionality and some of the needs, but things like residence and family councils embedded in legislation is an area where Ontario has led. And having integrated funding for associations of residence councils and associations of family councils are unique to Ontario. And so that is an area where other provinces can advocate to get that type of requirement, not a nice to have, a must have. And I think if we did have more voice for residents and families and caregivers and supporters, we would not have had that quote iron ring that we had located to block out essential family caregivers in so many cases, which then we know the enormously harmful effect that that's had. So in the end, I'm hoping that you are inspired to have a look at the action plan, which is what it is. It's not just another report. It's actually a mapping out of the ways that we can move forward together. And please help us join CanAge and help to raise your voices across this country. Merci à tout le monde. And it's been a pleasure talking with you today.
Great. Thanks, Laura. Thanks to all our panelists. So we have tons of questions, so I'm just going to leap right into them and fire away at you. We've kind of grouped them into some themes to try and give me fewer questions. So I'm going to try and do that. Nathan, I want to go. It's been a while since we heard from you, but I want to jump back to you with a really simple question. Someone's asking, why are people dying in long-term care homes again in the second wave? Didn't we learn anything? I know that's not a simple question, but can you give us just your thoughts on that?
Yeah, so despite the so-called iron ring, we know that these environments are not hermetically sealed. So as the incidence rises in the community, it will predictably get into homes, no matter, even though I would argue, are better prepared in some ways. There are things like universal masking. There's a greater understanding of the fragility of the sector. There's more recognition of asymptomatic transmission and atypical presentations. But the other part of that is, so they're not hermetically sealed environments, but the people who are workers live in the community. And when they're underpaid and when they may not have sick benefits in some cases, when they, in some cases, still there is a reliance on, in Ontario, on agency workers who can still work in multiple homes within a 14-day period, there is the potential to import cases into the home. So we are seeing that again. The full picture has not been, painted, so to speak, or the full story has not been written on, are we doing better this time than the first time? There are some early signs. I mean, I always tell people, how could we have done worse than the first time here in Ontario? So there are early signs that, the case fatality rate that I showed of 27% in Ontario might be a little less because we've had less collapse of the medical care systems within homes. But, we'll see. And we'll also see now hospitals are in a very different place than they were back in the spring when they were emptied out and when we could redeploy people to come work in homes. They're dealing with different stresses now. So if things continue to intensify as they are, we may see a real explosion of deaths within long-term care homes. So I know that's a sort of long-winded answer, but it's not an easy question. But again, community incidence rises, you're going to see outbreaks in homes. You cannot shield them. It's impractical and unethical.
But Miranda, I'll jump to you, Miranda, just to build on what Nathan said.
If I may add to that.
Underlying problems, understaffing, overcrowding, shifts not filled. Has any of that changed? How can we expect a different outcome if nothing fundamental has changed?
Unfortunately, nothing has changed. In actuality, I'm actually speaking to some of our stakeholders and partners through the association over the course of the last few weeks, both in home care and in long-term care. They've only seen not even 50% of their staff come back. The majority of these long-term care homes and the home care companies, they lost a lot of their personal support workers to the CERB, to fear, to family obligations, of course, and they're just not coming back. Why? Number one, there's no full-time positions. We're not seeing a lot of full-time. Now there are, I find it's actually more in home care where a lot of full-time positions are popping up and they're being innovative. But not so much in long-term care. We're still hearing, and then we're hearing about these resident care aides that are being hired by the province that are going into these long-term care facilities. And what these operators of these long-term care facilities are doing is that they are then decreasing the PSWs hours and giving it to the resident care aide in order to save money, shall I say? So there's a lot of different factors and things are just, I don't know, there's a disconnect happening, a really big disconnect. And we need to ensure that that stops because if it doesn't, what Nathan said.
Yeah, so not a lot has changed.
No.
So lots of questions about standards of care. So I think I'll start, Linda, maybe I'll start with you. You mentioned there's a question about the how. How do we do this? So if we all agree there should be standards of care, there seems to be almost unanimity here. How do we do it? You said we don't want to open the Canada Health Act. That's maybe a Pandora's box. How do we do it practically, have national standards, Linda?
The politicians, that's their job. That's their job in Ottawa, virtually or in person, to guarantee to Canadians that we have an appropriate quality healthcare system. We need to do the same thing with long-term care. Now, I see strings attached. Laura is a lot more eloquent than I am. She said tethering, something like that. I had to check it out, but you know, that's what it means. We have to make sure what the federal government says, the money won't go for more private. I think it's Nathan that talked about what 54% of the cases and deaths were from private homes, not for private homes or for-profit homes. We have to make sure our tax dollars don't go for profit. We have to make sure it's about safe staffing. We have to make sure, like Laura's very concerned, and Nathan too, that they do not become mini hospitals. They're homes, but they have to be safe homes. So I could go on, but it's the federal governments. We have all these MPs in Ottawa and across Canada. They have to take this seriously, and they have to put money where their mouth is, which means financing the province and territories so they can deliver proper health care. But don't tell me that a province that's doing as bad as Quebec and says, oh, just send me the money, I don't want your standards. Like, really?
So you want them to buy change.
So Andre,
yeah, Doris, I want to ask
if I can add, because not only we are pushing that, but actually I had a very important conversation with the Premier today and with the Minister Elliott, because we're actually asking even more than that. We are asking DAC 4 to become actually the champion for this. And I'm quite willing to go and see the Prime Minister with him. The reality is this: there is no way they can get away from the 4 hours, not in Ontario, and then if it's not in Ontario, not nowhere else. So the Prime Minister is saying national standards, that goes with money always, we all know. We did that already. We did that during the time of the health accord in primary care. This is how we moved this country to team-based work. They put a pot of money. They said to the provinces, those and territories, those jurisdictions that want money, this is what you need to do. And so no different here. There is no need, and no one in their right mind will open the health accord because it will be everything privatized. So no, you don't need to open. You put a pot of money, and if Quebec doesn't want the money, so be it. Let them manage themselves. But Ontario, we are suggesting does want, and we start to move to the 4 hours. Someone needs to start to move with that. And we believe that the Premier that already committed to the 4 hours needs to take it and needs to move on. And he has a recipe for this already. So there is no excuses, no excuses. And if we don't succeed now, we will never, ever succeed again, never.
And Doris, let me ask you another question, because several people have asked this one. They're saying, are you aiming too low? You know, this 4 hours, it comes from a study, it's almost 20 years.
4 worked hours, worked hours, which if you look at government lingo, is really more like 4.25, 4.5, because you put the sick time, they put everything there, right? So it's like Linda said, I go with the same, give us 4 worked hours, we will kiss everybody and we will go and make it work and deliver better care, because we will be able to. It's impossible now. When you say, why are seniors getting sick? Why are residents and staff, by the way, also getting sick? It's not only the issue of the fragility of those residents. They are already compromised when they go to a nursing home. Yeah. They don't have the staff even to give them to have a sip of water. Thank goodness we have the family back in. They don't have staff that can sit and help them eat, whether it's PSW, or they don't have the nurse that can do the assessment. That's why they're dying. And I do not think for a minute, Nathan, with my heart, with my broken, I'm devastated by that, because I think we will be as bad almost as the first round if we don't do something quick. If not worse, Nathan. This is still early days of the second wave. We have not seen when people will be inside their own homes, of how this will continue to spread more.
Well, I'll invite you to read some of the comments, Doris, because people are thinking you're aiming low. They're saying 4 hours isn't enough, but we'll come back to that. So Shirley, I want to bring you in. Can you do 4 hours of guaranteed care in the home? Is that
4
the
work
standard?
hours.
Does it
You
have
know
to be-
what?
Yeah, work hours. Shirley, can you do that in home care?
Yes, is the short answer. And, you know, I could say perfection has created, I think, some of the lack of activity in this area. And to be honest, whether it's long-term care and hours of care or home care, I used to think, no, we have to talk bigger. And we have to talk about the big vision of keeping people safe with high quality and engaging and shared decision-making. And then these beautiful standards will become so obvious and they'll fall out. Now I'm there, the heck with it. Give me any numbers, any funding, any money, and we will actually move the needle a small amount. And I agree that we need to not only improve the hours of care in long-term care. I mean, back in 2008, the hours of care were roughly 2.5 to 3.2 throughout Canada. And now, as we know, the case mix has changed, the environment's different. And I had always thought guidelines would make a whole lot of sense. Right now, I suggest your most important question was, what do we need to do to stop the chatter and actually begin to invest? And I wonder if the problem is not ageism.
Oh,
That we actually don't care about the aging population. And we're valuing a different component of healthcare and society. And maybe call that out, because it can't be that people have not heard, and it can't be that we don't have evidence. And that's where I'm now prepared to say it, give me anything, which is quite bizarre when you think about it from an evidence point of view. But I go, give us anything that improve and make a dent in the universe for dignity, compassion, and care for the elder population. And in my mind, that is the compelling federal direction that they will not be able to hide from. Whereas if we tinker with, well, is it 4 and is it 3 and should we just have principle standards? I think they'll be able to hide from that. And that's where I think we have to push a movement that says you care about older people in Canada and the lives they're living or not.
yeah.
And if we do, and I believe we do, then this is what needs to happen.
Yeah, great, well stated. Make it a philosophy, not just a little tiny points of budgeting. Great. Now, Miranda, we have lots of questions about staffing and PSW staffing. You didn't talk a lot about pay. We talked a lot about in this crisis that PSWs are underpaid. If we increase their wages, does that settle everything, or is there more to it?
There's far more to, you know, trying to keep and bring in new PSWs, et cetera. There's been a history of shall I say, for lack of a better term, throwing money or pay incentives to personal support workers in the past, going as far back into the 2016 budget, where they were putting a ton of money into the PSW sector, but that didn't help much, as has been made very obvious through this entire pandemic. You know, PSW is one of the things we hear from our membership is the lack of title protection, the lack of professionalism of the sector, to professionalize the sector. I mean, we all know that every healthcare aide, PSW, CCA, PCA, et cetera, across our nation, they're unregulated. So we all have different standards, we all have different training, we all have different everything, but we do the same job. And I think that we would be a better, and it's also not fair too, and I just want to play into this because I am here with the RNAO. It's not fair that a personal support worker, shall I say, here in Ontario can go and abuse, shall I say, or be accused of abuse or neglect and go down the street and continue to work as a personal support worker without any accountability or any, you know, criminal charges, etc., because there wasn't enough proof, and they can continue to work on as a personal support worker, but a nurse can't. It's not fair that a PSW who's done wrong is able to continue to work in their and practice being a PSW, whereas a nurse can't. There has to be a level playing field here. There has to be a level of accountability. There has to be a level of recognition of the vital role that these people play in our society, and stop downplaying it. And let's really start working as a team. We keep talking about working together and moving this initiative forward. Personal support workers, or like I said, any other name across our nation, we are a very important part of that move forward.
And a related staffing question people are asking about, we heard these big promises from Quebec. We're going to hire 10,000, they call them orderlies in Quebec, but PSWs. Do we have any idea where are they?
It's the same thing here in Ontario, Andre, where they're offering up these supportive care providers, resident care aides, come one, come all, come be hired and help us in our long-term care homes. Nobody wants to do it. That's the biggest issue. It's a very scary job. It's a scary job all the time, frankly, but right now with the pandemic, no one wants to do it. We're not finding the enrollment rates. We're not finding volunteers lining up at the door to do these jobs, unfortunately.
So I do want to make a comment that's fascinating, because in the case of nursing, and that is internationally, not only in Canada and in Ontario, the increase in people that want to become nurses and RN in particular is huge. It's a phenomenon. It's a phenomenon that we're all for people that want to actually join the profession. It's fascinating. It's a unique tribe.
Mm-hmm.
Shirley, I see you want to jump in there.
Yeah, I was going to jump in actually with the PSW and the various classifications. I think what's critical is that we come up with really effective, innovative educational models that don't water down the skills and the training for the personal support worker,
Exactly.
but maybe fast track. We've put in place, and I'd like others to put in place, a model where from both tuition and being able to start to work, let's say as a home support worker very early on, and then move right into the personal support work education. And then the home care provider or long-term care provider can right away begin to use that. Let's call it an innovative co-op process, but it totally respects the hours of training and education. It fast tracks it. It helps these people to be employed quickly, and it gives them an environment where they have a full-time job after in a very quick way. And we could draw from industries where there's been significant layoffs. What I don't want to see, and we are beginning to see it, is fast, knee-jerk, fast, quick educational initiatives that simply water down the competencies and the skills of the personal support worker. And I'd like people to look at the model SE Health has put in place, not just to use our model, but to force these innovative approaches that many educational groups and facilities could put in place today as we speak, because I would hate to see that we compromise care once again. And we'll get the 4 hours of direct care, Doris, but they'll be from ill-prepared and educated workers in the system. And that, in my mind, puts us behind versus moving us forward.
Yeah, an important point, not just hours, but quality of care as well.
Can we touch, Andre, on the issue that Laura brought, which I think many of us share in this specific panel, and it's the centralization of power in the hospital sector versus really strengthening long-term care, because it's long-term care, right? So some of the programs that Shirley just was talking, the latest one being called personal support aid, is yet a third layer. It's a 2-day education with the Michener invented by one of the teaching hospitals. And now it will be a 2-day training to support the second layer, which Linda mentioned, and that layer to support the PSW. So now you will have 3 layers rather than really, and they will be located in the hospital, and the hospital will send them, rather than really building the capacity in the nursing homes, in home care, in all the sectors, so we have a robust system.
I think you've frozen on us
that
there.
builds on community care.
Great. So Laura, I want to jump over to you. I'll come back to you, Nathan. Laura, because we have several questions about advocacy, and one of them is kind of a broad one. Someone's asking, what can a regular citizen with a loved one in care, what can they do to push for change? All this panel has great ideas, but what can your average person who desperately wants the system to change, what can they do, Laura?
Yeah, and I think, so many of us feel like we're just crying into the wind right now, because you may not actually be part of a group that has access into a premier or a prime minister. Regular people who care about the issue, many of whom have folks that are in some form of long-term care or in home care and are looking ahead as well. That's really why we founded CanAge, and that's why, we have our membership sign up. I've been putting the link in there as well. So canage.ca/join. It is important to have an organization which is nonpartisan and that can go and speak clearly to government and to share your voice. One of the other initiatives that we would really like, and you can see the opportunity to do so on our website, is to tell your story. Let us know your story. We'll have someone call you and take your story down if you like. We are collecting the individual lived experiences and stories from people, and we are able to package that up and share it as part of an advocacy. If you want to tell your story to a human being, we'll have one of our policy officers there. If you want to record it on video, you can share it with us that way. The last thing I think we can do is really try to make sure that when we're thinking about an action plan, focus in on particular areas of interest. If you are a caregiver, what organization can you belong to that can help you advocate and bring yourself forward? If you're not in Ontario, you don't have a provincial association for residence councils or a provincial association for family councils. You don't have that. That's actually a fairly easy thing to advocate to. Contact as well if you have a seniors advocate, and about half the provinces do, and about half of them don't. If you have a seniors advocate, reach out to that seniors advocate. And if you want any help navigating, I'm happy to have you reach out to me, and I will connect you with who you should be connected to, because it's your passion and it's your voice that actually makes positive change. So I'll put my information also in the contact details of the chat. Really happy to have you reach out to us, and we will help you navigate.
Great, some good tips there. Nathan, I see you want to jump in there.
Yeah, so echoing what Laura said, I think I'll just speak on advocacy, and I wanted to return to the previous point. I think one of the things that has been missing to some extent during the pandemic has been the voice of the resident and the voice of the caregiver as well. And I think they are in a difficult position in all of this, because there's a power imbalance and there's a lot of fear about retribution, and there has been threats of retribution to people during this time. So I think those stories, when they can be shared and when they are shared, are particularly powerful. To the previous point, I think all of this conversation about reimagining and transforming care is extraordinarily important. But I think, the sort of, for me, the view from 30,000 feet is we're in the middle of a pandemic, and we need both short-term rapid solutions and long-term solutions going in parallel. And so, it might mean that we water down some of the skill sets for workers to get boots on the ground right now, but it doesn't mean that that should be done at the expense. And I see Shirley nodding her head, but I'm looking, at provinces like Manitoba, and I'm looking what's going on there, where they're necessitating calling in organizations like the Red Cross. And I think we've seen this with other examples in our province as well. And I knew this would be provocative, but it's not that one or the other is bad, or that we have zero-sum thinking when it comes to this. The truth is we're in a catastrophe right now, and we need multiple lines of defense. And if we accelerate training, or if we retrofit some homes right now, it doesn't mean that we don't build new ones also, or reimagine what the system can look like. So I know that's provocative, and I think the point of this is for debate as well. So I'm curious what Shirley thinks to that point.
I have no problem with accelerate, innovate, and do things differently. I'm all there. Water down and have ill-prepared people is worse than having nobody, because at least if there's nobody there, we know what we're dealing with.
Yeah.
If we've got, quite frankly, half-baked resources, then we're really going to have a trouble with infection control, COVID spread, all those kinds of things. So, and I think there's enough innovation in all of us and enough opportunity in sort of this digital age and world to figure out a fast pace that definitely can accelerate and will not compromise. And we will make sure that there's enough what I'd call preceptorship and moving that through. But we've learned for centuries this sort of quick solution where we have watered down all of the professions in some way, shape, or form. Who loses in that most, first and foremost, is actually the patient and the family more than anybody.
Linda, I wanted to bring you in. You're a veteran advocate. You talked about, we treat a lot of our staff like crap. How can we instill some respect for nurses and PSWs and physicians and all these other titles we have? How can we make the system more respectful of them?
It's listening to them. It's having them at the table. It's and you heard Miranda talk about it. It's providing full-time jobs, benefits. Why does a long-term care or home care worker has to work in 2-3 facilities? SARS told us you do not do that when you're talking about healthcare, and never mind this virus, but any other virus. If we'd be having an outbreak of influenza, you don't want these workers to have to go work in 2-3 healthcare facilities. So it's a question of respect, but we don't do it. So that's why that 80% of the deaths of COVID-19 are into long-term care, because we don't do it. So when will we learn? We thought in Ontario we had learned with SARS. We had the Campbell Commission, which talked about the precautionary principle about stable staffing, trained staff. We thought we had got it. And something happened in March of this year that Ontario changed their mind and followed the federal government's guideline, which were watered down guidelines for healthcare workers. So that's just on PPEs. And now you're hearing everyone talk about, oh yes, we need to give them $4 more an hour for 3 months, then it's out. Then you have to stay home if you have symptoms. Oh, I don't have any sick days. Oh, we'll give you a couple just for this Band-Aid. We're in wave 2 and they don't have sick time. So it's about equal partnership, and it's about equity into benefits and salaries similar to what we have in the hospital. And that's when we will be at equal footings. So if we don't get there, we won't be there.
Andre, so RNAO, I don't know if you remember, was the one that called and insisted for the SARS inquiry. And this time we said we don't need an inquiry. Not inquiry, not commission, not nothing, because they do nothing. These reports serve as a delaying tactic. I learned that through all these years, for governments to do nothing until the next report comes. This is why now we need action, no more reports. I said that to the commissioner and he was not necessarily too impressed but they asked to meet with us, so we did. But the issue of the full time is not only an issue, and this is where ageism comes. It's not only an issue of SARS. It's not only an issue of COVID. It's an issue that if you do not have full time, you cannot provide quality care. You do not know those residents because you're in 3 homes. So it is an issue both that in the best of times is necessary to provide continuity of caregiver, that's simple, and also job satisfaction to the worker, whether that's a nurse or a PSW. And in the worst of time is that, plus the issue of moving the mess from one home to another. But never, you would never have a third of the workforce, actually 55%, almost 60% of the PSWs before this pandemic work in 3 homes. You would never do that in a hospital sector, never. When this province had 49% only full-time of nurses, we were up in arms, we went to Queen's Park, they lost the election, and McGuinty committed to 70% full-time, and we are there now. We need to do exactly the same now. Whatever it will take, it's now, because this story will not repeat again, and we have lost.
So Miranda,
many lives, and one of those lives.
Well, we lost you for a bit there, Doris, but I'll jump to Miranda. You know, we've known all these things for a long time. Full-time work is important. Continuity of care is important. Benefits are important. Miranda, why haven't we done it? We've talked about it for 20 years. Why hasn't it happened?
You know, I really think it boils back down to regulation of the sector. I think it's easy to control a sector that is not regulated and is not fully unionized. You have personal support workers that are parts of unions and PSWs that aren't part of unions. Then you have PSWs that work for-profit, not-for-profit, PSWs that work for home care, private home care, publicly funded home care. I mean, PSWs literally work everywhere. And by keeping it splintered, unfortunately, the government is maintaining control. That's literally what it's all about. And by doing that, how can you change a sector if you're so splintered? I mean, every time I talk to someone and they say, well, you know, the long-term care PSWs, you know, the home care PSWs, no, they're all PSWs. Stop putting different titles of where they work in front of their name. They're all personal support workers and they all deserve the best and they deserve you know, professional respect. And by having that, then we can start to cement and make the changes that need to happen. But until that happens, it's going to be very difficult.
And Nathan, we have some questions about infrastructure. Can you talk to us about, you know, we have these massive old homes. Is a big part of this fixing the infrastructure, making better facilities, and then of course staffing them, but are the buildings themselves important?
Sure, everything's important. You know, I think this was sort of my last point, which I sort of inserted 1 and then 2 feet into my mouth. You know, the point I'm trying to make is that there are, you know, as someone, I think Kami just wrote in the chat, I mean, there is an urgent crisis going on right now in staffing. And to Miranda's point, you know, even if you throw money at the problem, who are you going to hire? So there needs to be some immediate action taken. That doesn't mean that it's at the long-term expense of, you know, transformation in the system. But yes, infrastructure is hugely important. I think one of the things which I showed in my presentation was the issue of crowding in homes. And we've known that, you know, that study, it came out, actually, it was published today, but we did it months ago, and they changed the regulation in the province to no longer admit residents to 3 or 4 person rooms, but it didn't deal with the residents who were already in 3 and 4 person rooms. And then we learned that over the summertime, they actually started to admit people back into the 3, 4 and 4 person rooms, recognizing how deadly the situation was. So yes, we need infrastructure right now to try and decrowd homes, and that might mean moving people to temporary locations. That's the short-term solution. The long-term solution is that all homes in this province should be single occupancy, which would be much better for infection control. And actually, we know better for quality of life as well. So that's that sort of, obviously moving people to different locations is going to have risks for their behaviors. It's going to be difficult to staff. It's going to be logistically challenging. But it's this, again, we need short-term solutions. We're really in a battle here, but we cannot lose focus on, I think, what Doris in this event is aspiring to, which is the overall transformation we need to fix the underlying problems that got us here in the first place.
And Shirley,
I jumped in.
Is fixing homes just part of is it getting rid of homes too?
Well, no, I was going to say, did you see my slide, Nathan? Because what it did was demonstrate there are beds in the community that don't need infrastructure, that don't need developers.
Yes.
And we don't need to put money there. And if we put half of the money that is in to develop these new beds, it's going to take a year or 2 and actually created a more robust approach. And it's not just that it's just all home care, but to your point, we need some immediate solutions today. One, wave 1 would not happen. We would not have transferred everyone to a long-term care institution. And in fact, evidence has shown that 40% of those people actually could have been cared for in the home, not with our current home care programs, but with a very different approach to ask people, what do you need? And what will keep you here? And what do your caregivers need? So it really is a shift away from long-term care capacity has to move beyond beds and institutions and hospitals and into a much bigger community space where there's those beds in the community. There definitely are institutional beds, and there are people who do need to go into the hospital. But how do you rebalance that? What that means is you actually have to take away from some things now and put them into a different component, or you have to make the pie bigger.
Absolutely. I mean,
I
yeah,
like what Laura said. Did you read in the chat what Laura said? Care at home. Whether your home is in the long-term care facility or whether your home is in your home, or, you know.
Yeah, and I actually think, Laura, it's a very good repositioning rather than talk about home care, because it gets people into a headspace of what those challenges are today and what they have been. To care in the home for people could open up long-term care capacity in a snap. But we have to make sure we're true to families, that we can provide the care to them and not
absolutely.
Not download to them.
Yeah.
Surely, I mean, you'll know. I mean, when we look after patients in the hospital, we'll say, what's the maximum number of hours you can get of home care? 1 hour a day, 2 hours a day, right? In the community, and people work. People are unable to take that on, and so we make it an impossible decision where it's the only choice that people have, when it should not be that case. I fully agree.
Yeah, and we need to look at the integrated care hub models as well. So taking the bricks and mortar out of integrated vertical care. The good thing I say is what I'm telling people, the good thing is we actually know how to do this. We do. We have the evidence.
We need this.
We have the capacity. We actually know how to do it. And so very often when we're trying to work with governments to make seismic shifts, which is really what we're trying to do, it's not a systemic shift, it's a seismic shift. We need to provide them with very clear action items, which is why we created the Voices of Canada Seniors, so they could literally just do it. We're creating the policy backgrounders and working with the federal and provincial governments to kind of hand the law reform, not just the reports and evidence and so on that we have, but actually create the backgrounders and the legislation for them so that it's easy. We are also right now creating scorecards. And this is a very persuasive thing in advocacy. So if you can go and show the government of Manitoba that the government of Nova Scotia and the government of British Columbia are doing X, and lay it out in a grid, because these are not experts, right? The people who we elect are not experts in this matter. They're people who are trying to engage in public service, and they have to think about forestry and foreign affairs and 16 other different things. You need to make it very crisp, succinct, and clear in your advocacy. And if you can hand them a scorecard with the recommended legislative changes, and ideally the budgetary allocation for it, then you can actually get the change made, because they can wrap their heads around it. Few short words, lots of visuals, and a clear ranking and scorecard. That's how advocacy gets done.
Okay. And I want to, because I don't want to run out of time first, I want to ask people their priorities, because there's so much to do. So I want each of you to tell me what has to be done first, what has to be done tomorrow. Maybe I'll start with you, Linda. Where do we start to fix this?
National standards, which will be the overarching plan for long-term care, but it can't be done without the funding. If there's no funding, don't waste the ink on the paper.
So standards of care, number one.
Mhm.
What would you do next?
Good jobs. If we make it good jobs, people will go to good jobs. I always say it's called retention recruitment, because if we can't retain the staff we have now, we will never recruit in the sector. And right now it's an area, you heard Miranda, it's an area where people are scared to go work. They've seen the workers in garbage bags. They've seen the awful pictures. They're scared, which it shouldn't be. It should be a home where you are providing care to seniors, your grandparents. So fix the workplace, the working condition, and people will go to the sector.
And the research shows us clearly where there's a good work environment, there's good care. So win-win for the patient.
And win-win for the budgets too, because your residents won't go in the hospital sector. They'll be able to receive their care where they are living, either in home care, as Shirley was talking, but they will receive it. So then you're saving money. and you're providing better care, and you're saving money in your retention recruitment because you're not always recruiting, you're not always training, you have a continuity of care.
Great. Miranda, where would you start?
I would just continue on the train we've been on, try to regulate the personal support workers in the province of Ontario. You know, it's title protection is needed, accountability, looking at full-time positions, a national standard for long-term care, national standard for home care. I think that the federal government needs to become more involved in certain aspects of this national standards across the board, and a standardization of the personal support worker. You know, I want to start seeing some the same training across the board. You know, we can utilize these workers so much more than we already have, but by cementing their scope and their standards, etc. So we really want to see the regulation happen first so that we can move forward with everything else.
And are you confident this could happen in short order? Is the political will there from your sense?
We are currently at the table discussing regulation.
And that's new. You've not always been at the table.
No, this is brand new, and it's been within the last few weeks. So this is it's hopefully it's promising. Right? I hedge my bets, but it is what it is. Thinking positively.
Good to hear. These conversations aren't always positive, so it's good to have a positive note.
Yeah.
Nathan, where would your starting point be?
Well, I'm going to go out on a limb and disagree with Shirley again, much to my. So I, you know, Shirley said earlier on that, you know, which I do agree with about ageism, but she said, you know, I think we do care about older adults, and you know, I'm actually not sure that we do more than giving it lip service during this pandemic, and I think it actually is more than ageism. I think there are many intersecting forms of discrimination when it comes to people in long-term care. There's there's the issue of dementia-related discrimination, and the fact that the majority of people who live in long-term care and work in long-term care are women. And I think, you know, in the time of COVID-19 and in the year 2020, where we've had so much reckoning about systemic discrimination, somehow ageism, as it always does, has fallen outside of that, as well as these intersecting forms of discrimination. And I think that, you know, all the things that are trying to be accomplished here may not happen if we don't have a serious conversation about why this is not an issue of importance in society. And I'm not convinced, Shirley, that we do care as a society about fixing this, which to me is the most fundamental problem about all of this. So now I'll back up to let Shirley rebut me, because I've already, but no, seriously, I think that's the fundamental thing in my mind about how this problem can be addressed.
But before she does that, I want you to expand on that, because, you know, we know the vast majority of caregivers are women, the vast majority of care providers, the vast majority of patients are women. This is really a gender issue. We don't talk about that very often.
I can help with that, Nathan.
Go ahead. No, I mean, I always, dementia and older care issue is a feminist issue. It really is. And, you know, and that's, you know, we have to think about why we do not make this an issue that is properly addressed. And I really believe it's that intersecting forms of discrimination that make it an issue. And the other thing is, frankly, as a political issue, how many long-term care residents vote, and how many of them are going to be alive for the next election, right? They're an easy, and how many of them can advocate for themselves? So it's an easy population to not, you know, address it and put money behind.
And the fundamental part of this part of the discussion is, tell me what you want done about it. So what's the priority? How do we fix it?
Well, you know, I think that, you know, I think that there has to be some way. I think we've seen it this year where, you know, systemic racism had gone on in society unchecked for years and years and years. How do we have that societal conversation and reckoning with issues like ageism in the way that we have in other movements in the last 5 years? I actually don't know the answer to that, but I really actually believe that is the fundamental issue underlying all this transformation in long-term care and care for older adults. It's how do we take it from being the last socially accepted form of discrimination to make it one where it's no longer acceptable, where people are called out for the language that they use, where people have real repercussions for actions and policies that are ageist. And frankly, we haven't found a way to do that. And actually, I might turn that around and put that on you, Andre, to ask what you think could be done about that, because I'm actually have been stumped as a geriatrician and as someone who has tried to advocate. And I know that you've always been a huge advocate for older adults and have brought up ageism, but I don't know how we leverage the sort of the social movements that have taken a foot in 2020 and bring in older people into that conversation.
Great. And I'm going to give the floor to Shirley, but I'm expecting to see you at the front of an Elder Lives Matter protest soon. So I think that'll be so Shirley, I know you want to rebuttal and you want to tell us what you would fix first.
Actually, the sad part is we're not in disagreement, Nathan, and I do believe it is the power of the people. My starting point would be start with what people want and listen and respond to it. I'm a believer. I'm a terrible reader. I always go to the end of the book and then go backwards. So with this, it's sort of, once again, what do people want? And we have to listen and respond to it. And personally, I think we have to give them a soapbox so they're screaming and shouting from the trees about what they want. So it will force government and it will force us in healthcare to respond. And I think that is critical, because then it's not our voice, it is the people's voice. But I think we have to get them on a soapbox and give them the freedom and the opportunity and the empowerment to speak up so that we can hear and listen that. In a very secondary way, again, it's sort of big picture. I think that we should, at a minimum, meet the OECD average of 35% of our resources for senior care going into the community. 10% is just, no wonder we're reorientated. We are over-rotated on beds, medical care, institutionalization for decades. And unless you rebalance that, at least in the first piece of the pie for senior care, to meet at least the OECD standard of 35%, all of the other things we're talking about, talent, standards, all of the very important pieces that give this life, it's the bigger piece. But I also think we have to rebalance the big pie of healthcare spending, because if we don't, we'll never get out of this rut of not enough hospital beds, not enough, emerge entrants to get people in, because we will not be building the robust community and chronic disease infrastructure support to keep people actually out of the system. But little pieces, and I think we have to multi-prong just a variety of different interventions, high level, low level, in between. We have to empower the people to speak up. Why? Because we've all been talking for years and years and years. So this is where I go, what's the problem? We have loud voices, we're very passionate, we're really trying to move and push the string. So now I think we have to move the microphone to people and hear what they have to say. And I know we can respond to it, but we have to give them that voice.
Great. And speaking of the advocate voice, we'll give the last word to Laura. I was going to ask you what your priority is, but you tweeted and posted it, but tell us a little bit about it à vive voix.
Thank you. I think there's two pieces. So first of all, I would agree with all of my colleagues. Yes, national standards. Yes, tethering. Yes. But I think fundamentally the one I'm going to choose is our recommendation 49, which is sector building on aging. We need to invest and prioritize in sector building on aging, which means educational incentives to enter these needed fields, requiring to support our aging population. We need to integrate professional and employee development in our health and social care in geriatrics. We need to design specific investment envelopes for innovation and technology to promote age inclusivity. And we can do all of those things in addition to national standards and in addition to staffing. But one of the reasons why we're not doing as good a job is because we have not invested in our seniors care sector. Fundamentally, I think it's because of ageism, but I also think that there is an economic argument which can overcome the ageism inherent. And I hate to say that I think money will overcome discrimination, but because it's not just a cost, but there's an advantage economically right now, I believe that that point, as we're entering into what will be an austerity winter, may be the new lever that we've never had before. So economic investments may counter some of our ageism in this COVID time.
Great. And we've gone way over time because there were so many questions, such great discussion. But I want to, before we wrap up, I want to give the last word to Doris to send us home with some thoughts.
So, Andre, I think that it's good that you left me last because I will build on my colleagues. Starting with Nathan, it is discrimination. And I will give you 2 reasons why we ought to know, if we are honest with ourselves, that it is discrimination. Number 1, in Canada, 81% versus 38 or 40% on OECD. So why in Canada? Because we discriminate against older people. Second, the investment in Canada is significantly lower than in many OECD countries for seniors. If that's not discrimination, tell me why. Third, the workers that work in long-term care are racialized, immigrants, refugees, you name it. So that's discrimination, and that's why they have poor type of jobs versus good jobs like in Europe. And I can give you many more reasons. So I said to the Premier today, and I hope some of his staff are listening to this, and I don't regret saying it, and I will say to any Premier that comes to ask me any question, I want to know in which office and who exactly made the decision to abandon seniors in long-term care facilities and their families. Because such a degree of discrimination in a country that has the means like Canada cannot just happen by chance. Cannot. This is a decision that was made somewhere. Because if it was not, then we wouldn't be seeing the disaster we are seeing now in the second wave. So yes, it's a decision to abandon seniors. And if it's not, give me the 4 worked hours of care. In whichever reiteration, we can discuss the details, but put the money where the rhetoric is, because if not, it's abandonment, period. And then once we have the hours with good jobs, let's move to person family centered care, or as my transgender group in long-term care has taught me, chosen family. So let's go to person and chosen family care, because that is also discrimination. And I would suggest to you that once we start to move there with good jobs, as Linda said, and as Miranda said, and Laura, etc., we need to layer to that emotional care, and not only emotional care. Residents also need good clinical care. And that's why PSWs alone cannot do that, Miranda. And that's why we agree on what we agree. Because a fall is a fall, a pressure injury is a pressure injury, dementia is dementia. So you need the mix of good care, emotional, social, and physical. And for that, you need evidence-based practice. And I hope you will have good news on that soon, because we are actually looking at a revolutionary program that we already started with many nursing homes with evidence-based guidance. This will be even bigger. But you know, it is discrimination, and we need to be honest about that. Hence why, Andre, we need to continue the conversation, because we didn't have enough time to answer even half of the questions. So that's the date. I'm going to call back the same panel. If Andre is willing, he will moderate. If Andre is busy, we will need to find a moderator, but we need to nail this down until we make change happen. And more, we want to see also families in the panel. Families actually speaking in the panel. Because if we don't succeed now, colleagues, friends, families, loved ones, everybody, if we don't succeed now, it never will happen. This is our last kick at the can. And the reason I invited the people, and I invited Andre, because you are outspoken. Nathan, I told Nathan, not only he produces data, he says it as it is, and people need to hear that. And Shirley, I don't need to say about Shirley or Linda or Miranda, we are all outspoken. But Nathan, I want to say a special thank you to you, because there are not many physicians not only in long-term care, overall, that produce good data and speak about it with integrity and with courage and without fear. So I do say a special thank you to you, because if all the gerontologists and all my colleagues that work in long-term care, whether it's PSWs or nurses, will speak out, we will not be in this mess, because the families for sure will come with us, no doubt about that. But the families are, you can hear them in the chat. They're eager, they're thirsty for us to make change happen. So we owe it to them. Many of them lost family members. Many of them lost loved ones. And many of them may lose loved ones if we don't take more and more action. So thank you, Andre, for trying to manage us at least.
Great. And thank you, Doris. A good sober ending, but a fitting ending to remind us that we owe this to our loved ones. We owe it to our elders who've done so much for society to get this right. So I'm going to finish by, of course, thanking our panelists, Laura Tamblin-Watts, Linda Silas, Miranda Ferrier, Shirley Sharkey, Doris Grinspun, Nathan Stahl. You were all terrific. And I want to end with quoting someone from our chat, Linda, who typed in best panel discussion ever. So hopefully we can do this again, and we'll try and keep it up to this excellent standard. So
and tweet. They asked me to remind you to say 4 hours for seniors, number 4 yes, hours for seniors, and we will keep pushing together, guys. We must.
Spends all my time on Twitter. I should have given you the hashtag 4 hours for it. Thank you. Good night.
Thanks, everyone.
Thank you so much, Andre. Thank you, everybody. Thank you, Laura and Miranda and everybody. Shirley, thank you so much, everybody.
Bye-bye.
Thank you. Bye-bye.
For your leadership.